If you want to sit back and relax and not take notes, you can do so. All the information presented in this webinar, or most of it, will be freely available to you through our therapeutics letter, which is available on our website. And I'll be referring to other letters that indirectly deal with anticholinergic drugs that you can also access from our website. So I just want to have you pause and think about if you had a list, if you had to list out for the top 200 drugs prescribed in BC, how many of them do you think would be anticholinergic medications, and could you list them off? So in your mind, think of that list, and I'll share with you the actual list. And our suspicion is that you will recognize many of the drugs on the list as anticholinergic. I'm sorry, someone still has their mic on, and just for the courtesy of the other participants, if you can please make sure you mute your mic, that would be appreciated. So as I was saying, I think a lot of the drugs that you'll see on this list may not come immediately to mind as being anticholinergic. So let's take a look at that list. So we've got amitriptyline and nortriptyline, the tricyclic antidepressants, and we have several antidepressants and antipsychotic. So I would consider that if this happens to be on the top 200 prescribed drugs in BC, that many of you have either encountered patients that are on these drugs, or you have prescribed these drugs, or you have encountered situations in which you've had to deal with situations related to these drugs. So it's a very common situation in British Columbia as far as we can tell. And don't forget the over-the-counter medications that don't require prescription. Benadryl, Gravol, or their associated generic names you can see there, and many cough and cold and sleep over-the-counter medications contain anticholinergic medications. So let's go over some well-recognized and not so well-recognized consequences of dealing with anticholinergics. But first, I'd like to start with some of the well-recognized problems with husbands. My colleagues at the TI peer-reviewed my slides and suggested I take out the bad humor. I decided that that was not a good idea. One of my calling cards is my terrible sense of humor, so I left it in. So one thing I think all people should recognize is that your husband's shape will shift over the course of the marriage. And in the pre-I do phase, they probably look something like this. And it's well recognized that as soon as they say I do, within a couple of months, their bodies will start to deteriorate. So that's fairly well recognized. Now, as it relates to anticholinergic drugs, one thing we suggest that you do is ask on a regular basis, are your patients experiencing well-recognized anticholinergic toxicity? And as a pharmacist and in other health professions, I'm sure you've encountered the different ways in which to memorize the typical anticholinergic toxicity. We're going to provide you with a list right now, and I've broken it down into some body parts. But before I do that, I want to share with you a video from my colleague, Dr. Tom Perry, of one of his patients that describes some typical manifestations of anticholinergic drug toxicity. And now keep in mind, this patient has consented for the use of this video, but only for educational purposes. So we ask that you do not share it if you access this webinar recording at another time. So here we go.
What was the reason you were taking the amitriptyline?
I just started it to help me sleep more.
Mm-hmm.
I really didn't realize until I started, talking about it, that it's probably aggravating some of my symptoms. For instance, I have problems swallowing, and I have a postnasal drip, and I have a very, very hard time with a dry mouth. And I've increased the amitriptyline because I've had more trouble sleeping. And from that, I found I've had constipation and trouble, can I use the word peeing? I feel I need to go, I want to go, but sometimes takes me ages to actually be able to go when I'm in the washroom.
What's the difficulty you've had that the speech therapist describes?
It's hard sometimes when I'm eating a meal at night or during the day. I just have to stop and really physically swallow.
Had you made any connection to the dryness in your mouth and the fact you were taking a drug every day?
No, absolutely not.
What was your own explanation of why it was so difficult to urinate?
I didn't understand it. I knew that there was something happening because I didn't ever have that problem before.
And what about your bowel movements?
But since I have increased the amitriptyline, it's been just like little pellets.
When you took it as a sleeping pill, would you expect in your own mind's eye that you take it and by morning it's gone, or how do you conceive of a sleeping pill?
I just feel that it helps me sleep, and when I get up in the morning, the effects have worn off.
I see. And do you think that's the case or not?
Yes.
Why did you keep taking it then if it wasn't helping you?
Because I thought I'd be in a worse state if I stopped it.
So I think that's a very compelling video and an example of how common anticholinergic toxicity may manifest. But there are also some hidden gems in that video in which she describes the dry mouth leading to difficulty swallowing. So I think a careful choice of words when asking questions is important, and we'll get to that. So let's, as I mentioned, go through some of the commonly known or well-recognized toxicities of anticholinergic drugs. So in terms of the brain, many have described, and in the product monographs, delirium or impaired cognition is listed. In terms of the eyes, dry eyes or dilated pupils, heart, tachycardia, the gastrointestinal tract, constipation, the mouth, dry mouth, and the bladder, urinary retention. So I don't think this would be new information to many people. But there are many not so well recognized manifestations. And I think the first one, as it relates back to husbands, is that my wife has realized over time that I don't listen to her very much, and my humor has become worse, and I'm less and less sensitive. And I thought this cartoon exemplifies that very well. He says to his wife, who's standing on a scale, "Don't feel bad, Loretta, the entire universe is expanding." So I'm sure many of you husbands on the line can appreciate this phenomenon. As it relates to not well-recognized manifestations of anticholinergic drugs, we've tried to list out on the left, you can see the toxicities we just talked about and how they may appear more subtly or more nuanced in a patient. So let's go through that. In terms of the brain first, there's some evidence that we'll share with you about the risk of dementia and possible hallucinations or brain fog. In terms of the eyes, it doesn't always manifest as dry eyes, or patients may not describe the issue around difficulty focusing. So for example, if you ask the patient if they're experiencing dry eyes, they may not know to tell you about difficulties with visual accommodation. And for the dilated pupils, if you don't ask specifically about light sensitivity, it may not come up in discussions with your patients. For the mouth, in terms of dry mouth, as you could see a little bit in that previous video, this woman described something in terms of swallowing, but dry mouth is because of the decreased amount of saliva, which can lead to tooth decay, gum decay, and potentially bad breath. So asking questions specifically about that would be useful. Also, it can lead to impaired speech. So if we ask specifically about that as opposed to dry mouth, that may elicit some interesting information from the patient. And also problem swallowing. In terms of impaired emptying or the gastrointestinal tract, leads to things like constipation, but also has been described as leading to heartburn-like symptoms. So there's another interesting phenomenon that may be occurring from here is if a patient describes heartburn-like symptoms and then gets prescribed a proton pump inhibitor for those symptoms, it may be that the proton pump inhibitor is trying to manage the complications associated with anticholinergic toxicity. So something to consider. And for urinary retention, I'm going to show you a video of a woman describing what she describes as having to go to the bathroom all the time, but never feeling empty. So being careful about how you ask those questions, and decreased sweating may lead to situations like dry skin. So here's that video.
I've had a chronic cough for almost 4 years now. As a result of the cough, to try and maintain a somewhat regular daily schedule, I've had to take Benadryl on a regular basis. On a regular day, I'll take 2 Benadryl every hour and a half to 2 hours. And that's just because I work in an office environment, keep from disrupting them, and plus home and family. My job requires me to drive long distances. If I have to get into a car, I can usually take about, I'm popping a Benadryl every 20, 30 minutes just to keep from having to pull over and get sick because I'm coughing so much. And like I said, that's just so I can actually have a good life. I haven't had any Benadryl today. A question that I actually asked Dr. Perry that was quite interesting is, part of my job, of course, like everyone, is the use of a BlackBerry. What happens is I'll look down at my BlackBerry, and it can be for a very short amount of time, 30 seconds, whatever. When I look back up, it takes me anywhere from 15, 20 minutes to regain my vision. Everything's extremely blurry, whether it be near or far. It's just I can't focus on anything.
On a long drive, sometimes you were almost seeing things.
On some of the drives, of course, like they're 6, 7 hours, and I'm consuming all this Benadryl, and I said, would that be why I'm driving along and all of a sudden I'm seeing things right in front of me and I'm going, whoa, and it startles me and I'm going, okay, there was nothing there. But I've never had that happen before either.
And what about your bladder also?
I'm always going to the washroom because it never seems to empty. I've tried all the tricks. I've gone on the internet, and they say stand up when you're peeing and the rest of the stuff. But I'm constantly going to the bathroom. It never seems to empty. And it's bad to the point where, if I'm coughing, I have to wear a pad most of the time because I do have leaks and stuff because it just never fully empties.
So I find that video also very compelling in that she describes toxicity. And if I had just gone by what I had learned in pharmacy school about urinary retention or the typical list, I may not have asked those specific questions to get that. Now, in this case, the woman was quite forthcoming with information, but it just highlights that we need to be careful about how we ask questions if we want to get all the information. And I thought of myself and how my wife has learned to be very careful about how she asks me questions. So I'll give you an example. Sometimes she'll ask me, when you have time, can you do the dishes? And my usual response is a blank stare, and I hold on to my can of beer really tightly and I stay on the couch and I don't do anything. And that was early on. And later on in the marriage, she does something like this. She basically says, why aren't you currently washing the dishes, with a stern look on her face. And I start to swear and mumble under my breath, but I'm quickly up at the sink and I'm starting to do dishes. So her careful choice of words has produced a very, very different response. As it relates to dealing with patients on anticholinergics, we have some suggestions for you, and they're mainly common sense suggestions. And I've learned this from Tom Perry, that for those of you that are dealing with patients, you may want to ask questions in this way or come up with your own versions, but let's go through them. And here's an example of an imperfect husband as well. In terms of skin, you could just say, are you experiencing any issues with dry skin, or notice your skin being overly dry? For eyes, do you have trouble adjusting from near to far with your eyes? So that would get at that situation with the woman and her BlackBerry, driving on the island highway, that she was having visual accommodation problems. And she also described it as blurry vision, but if we only ask blurred vision, we may miss something. And for mouth, we think it's probably a good idea to check in with your patients. How are your gums and teeth doing? Have you noticed any problems with bad breath? Have you had more visits to the dentist where you're needing more dental work done for cavities? Are you having any issues with swallowing? Do you find you have to make a conscious effort to swallow food? For the stomach, do you have any constipation or change in the type of stool you're having? And then also, are you having any symptoms that may be similar to heartburn that relates to decreased GI motility? So a careful choice of words again. And for the bladder, after you pee, does it feel like you can't empty completely? Or when you cough, do you find you have leaks because your bladder may not be emptying completely? So some basic common sense choice of words that might get some more information than the typical well-recognized toxicity from anticholinergics. Even the good ones are bad. So in many cases, this applies to husbands, and I'll share with you what I mean, but you'll hopefully see why I think this also applies to many medications on that list of drugs that we gave you at the very beginning. So for example, with husbands, it's nice when your husband remembers your birthday, but he buys you a vacuum cleaner as a birthday gift. So not super, super sensitive. And then another example would be, you're happy because your husband gets along with your mom, but how that manifests is he tells your mom she looks hot in a bathing suit. So starts off as good, but doesn't always manifest completely in that way. And how my twisted mind thinks this relates to anticholinergic medications is what I've learned from Dr. Tom Perry is that the product monographs for most prescription drugs are full of interesting information. And in those monographs, you can find interesting clues. So for example, if your patient presents with what appears to be anticholinergic toxicity, or you suspect it, but you don't immediately see anything on the product or the medication list for that patient that makes you concerned, you may want to take another look at the product monographs. And they're easily found on Google by typing in, say, Celexa Canadian product monograph and doing a word search of that PDF document. And I'll show you some examples now of where and how you would find that information. And so basically it's using your detective skills. And this is also a place where pharmacists can be incredibly helpful, is to, when they're dealing with patients in, say, a community pharmacy setting, if patients present with complaints, looking at their medication list and then searching the product monograph for some more clues to see if you can find the drug that may be causing them. So one important example to consider, and this is a bit of trickery, I think, on the part of drug manufacturers, is the parent drug may not be anticholinergic, but the metabolite may be. And here's an example of such a case. So in the Seroquel or quetiapine monograph, it says, contrary to quetiapine, norquetiapine exhibits moderate to high affinity for several muscarinic receptor subtypes. And so any of your patients that have livers, this might lead to problems. If you go further into the monograph for Seroquel XR, it's clear. If you were to do a word search for anticholinergic, you would see it says possesses anticholinergic properties which can lead to adverse drug reactions such as gastric or urinary retention. In other cases, it's wise to look at the mechanism of action section and or the adverse effects section. And sometimes they don't align. So the mechanism of action may not suggest the drug is anticholinergic. However, the adverse event profile of the drug looks very much like an anticholinergic. So here's an example of venlafaxine or Effexor where, oops, let me go back one slide, sorry for that. It says venlafaxine has no significant affinity for muscarinic receptors. And then it goes on to say, if it did, it would produce anticholinergic toxicity. So I found that a very interesting choice of words, that basically saying this drug doesn't behave like an anticholinergic, but if it did, it might produce this set of problems. Very strange. If you go to the toxicity section, it does say that it produces constipation, dry mouth, nervousness, anxiety, blurred vision. So I'm not sure how those two align. For me, if I was seeing patients or if a family member came to me and was on venlafaxine, I might want to warn them that they may experience this kind of toxicity. And it may not be that important that the product monograph says that it should be behaving like it based on the mechanism of action. We saw a similar example when we published our letter. We had a comment on our website about trazodone, where someone pointed out that apparently it has no affinity for muscarinic acetylcholine receptors, and can you explain? And we responded by saying that, yes, we agree that the mechanism of action in vitro doesn't appear to say that, but the adverse event profile of trazodone makes it look like it behaves like an anticholinergic. And it could be an issue around unrecognized effects of metabolites that could be leading to why trazodone behaves like an anticholinergic in terms of toxicity. So something to keep in mind. And again, here's an example of how I did it. I just pulled up the product monograph for mirtazapine online as a PDF, and I hit Control F and typed in anticholinergic, or you could type in dry mouth or constipation or blurred vision, and it would appear. So it's very, very simple to get the most out of a product monograph and figure out if the drug that you suspect is the source of the problem. They mess with your mind. And again, this is both husbands and anticholinergic. So let's start with husbands as to follow the pattern. I love this sign that I saw in a hardware store. Ladies, if a man says he will fix it, he will. There's no need to remind him every 6 months about it. And if you talk to my wife, she would agree with this completely. So as it relates to anticholinergics, we already suggested that the well-recognized issue of cognitive dysfunction is a problem with these drugs. And this suspicion or signal that exposure to anticholinergics over a long period of time or at high doses may increase the risk of developing dementia. So we'll share with you a summary of that information. Cognitive dysfunction, even in the short term, has been described with a number of drugs, and a quick search of the product monographs will show this. For example, if you, actually, let me start with some of the observational studies. Now, I'm not presenting you the findings from a systematic review of all observational studies on cognitive dysfunction. I'm just sharing some highlights. But in this particular study, drugs with anticholinergic effects led to an increased odds of cognitive impairment. In another study published in 2012, non-amnestic mild cognitive deficits were consistently induced by first-generation antihistamines and tricyclic antidepressants. And the quetiapine monographs list confusion in the adverse event profile for this drug. Citalopram monograph lists confusion and impaired concentration. And getting to the issue of anticholinergic drugs and the risk of dementia, one of our colleagues, friends from the University of Washington, several years ago published an observational study suggesting a signal where patients with a high anticholinergic drug cumulative burden ended up having a higher risk for developing dementia. Subsequently, Dr. Shelley Gray and her colleagues published a systematic review, I believe in 2016. The reference is at the bottom of the slide, where they found 4 observational studies all showing the same signal. And what they found was, with longer term use at higher doses, if the cumulative anticholinergic burden is high in a patient, there's an increased risk of developing dementia. And it was about 1 in 12 patients are likely to develop dementia with that continuous or high exposure. Now, when our epidemiology group looked at those studies, they suggested that it's not definitive proof. These are observational studies with all the associated issues. And right now it's an interesting signal. But Dr. Perry pointed out that there was another observational study published last year after this systematic review was published, and we'll share with you their results in this next slide. So their conclusions were there were significant increases in dementia risk with anticholinergic antidepressants. And you'll recall of the list I gave you of the common drugs prescribed in BC, many of them were anticholinergic antidepressants. Also anti-Parkinson drugs, antipsychotics, of which quetiapine is commonly prescribed in British Columbia, bladder antimuscarinics, and anti-epileptic drugs. So it's something I think we need to start paying attention to. And when we were thinking about it, we thought, okay, well, you know, the argument may be that these observational studies don't prove causation. But what if we pose the question in this way? If this information is true, this means approximately 1 in 12 patients exposed to a high anticholinergic burden may develop dementia. Is it worth the risk? And what we mean by that is a continuous and frequent reassessment of the need to continue anticholinergics is necessary. So if you're finding that these anticholinergic drugs, the indication is no longer necessary, or the indication for the anticholinergic is there. For example, if you're using an antidepressant for depression, or you're using an antidepressant for something like neuropathic pain, and the patient comes back and describes a situation where that drug isn't helping the pain or the depression, then it may be time to really think about the additive risk of potentially an increased risk of dementia in those patients where the drugs aren't serving their purpose and maybe causing other problems, and discussing with the patient whether a trial of stopping is necessary. So basically, we're coming to the end of our presentation, and we wanted to wrap it up by giving you some practical tips and suggestions and summarize what we've already talked about. First of all, we suggest the most important first step is to make patients aware of the possible anticholinergic harm that they might experience when writing the first prescription, or when they approach you and they tell you they may be using over-the-counter anticholinergics. And if you've inherited patients that are on a number of anticholinergic drugs, you may want to check in with them to see if they were informed by the person that originally prescribed those drugs. And we suggest that you ask the questions in a specific way, or make them aware of things like difficulty swallowing, maybe issues with difficulty with speech, or problems with their gums or their teeth, or urinary difficulties such as not feeling like they can ever empty their bladder. If you need references from the Therapeutics Initiative, we have 3 letters. One letter, 113, that is the subject of this webinar. Letter 105, which describes all the issues surrounding cyclobenzaprine, which is, if you're not familiar, a drug that goes under the brand name Flexeril. There are about 120,000 patients in BC that currently have a prescription for cyclobenzaprine. This drug is very, very similar in structure to amitriptyline. So it behaves very much like a tricyclic antidepressant, and all of those drugs are potent anticholinergics. So letter 105 can provide you some useful information on a commonly used drug in BC. Therapeutics letter 96 talks about the benefits and harms of drugs for neuropathic pain. And those drugs are primarily pregabalin, gabapentin, but also duloxetine, venlafaxine, amitriptyline, nortriptyline, diazepamine. So those latter drugs are all anticholinergic drugs. And so there may be some therapeutic pearls in letter 96 as well. They're all freely available on our website. And while you're on our website, if you haven't signed up to receive the letters by email for free, you can do so by clicking on the Get Involved tab, I believe. A couple of our friends, Joanna Trimble and Janet Curry, have recently published an article on the Canadian Deprescribing network website. That's a very useful resource, primarily for patients, but also for clinicians. and I'll show it to you, the front page of it to you. So it's a very, very simple document that covers all the basics. And it's a very, very useful resource in our opinion. If you just Google Canadian Deprescribing Network in the title of this talk, it will come up, and I believe it's freely available to anyone that wishes to read it online or download it. So we suggest you take a look. And Tom Perry pointed out to me that in some cases, we actually use certain drugs for their anticholinergic properties. So we intentionally use them. So for bladder problems or gut problems or dizziness problems. And we just wanted to make sure that you remember that when you're using an anticholinergic, because it's an anticholinergic, do you always warn the patient of the possible anticholinergic harm? And do you monitor or ask questions about those experiences on a regular basis? And if you haven't been, we suggest you do. And remember to consider using the questions as we worded it on the slide that had Homer Simpson on it. And our suggestion for you is, of the commonly prescribed anticholinergics in BC, are there some that you prescribe? And I suspect that many of you that are prescribers in BC probably have encountered situations where your patients have had some exposure to these drugs, and to make note of them. So one of the ways to do it, and I'm no expert with electronic medical records or which EMR products you use, but to investigate with your provider to see if there's a way to flag the known anticholinergics so that every time you see a medication list, there's some sort of an alert or flag that highlights to remind you that, oh, by the way, this drug is an anticholinergic. And here's a reminder of what that list looks like. So I didn't mention, but this webinar is being recorded, and the recording will be posted on our website. So if you don't have time to jot down this list, please don't worry. All of it's available or will be available within the next several days. If you're patient, you can view the video in its entirety later. Before I start that next video, I just wanted to give you a little bit of a preamble. This is one of Tom Perry's patients. Again, the video, she consented to it for educational purposes only. It describes many useful things that we've talked about today. I think it speaks for itself, and I ask that we pay particular attention to the last few seconds because it's a good reminder for anyone that has direct patient contact.
Is it all right if I make this recording for possible teaching use?
Yes. Yeah, well, forever. And the shakiness gets you down. Yes.
Now, one other thing that I forgot to mention to you before we get to the next slide is if you have questions, it looks like we're going to have plenty of time for questions at the end. Please enter them into the chat through the Zoom platform. And then my colleague, Alan Castles, will be collecting the questions that you submit. And if they're similar, he's going to paraphrase the similar questions and pose them to me. So right now might be a good time if you've had questions on your mind to start entering them into the chat so he can start seeing them. There's one more video of this same woman in a follow-up meeting she had. So I'll play that for you now.
The first video I made with you, you were kind of peering at the medicine capsule.
I couldn't read them.
I thought you were just missing your eyeglasses.
I have had my eyes checked. I've been told I have the eyes of a 16-year-old. He said, you need glasses only for when you're doing your crafts, you know, to magnify something.
So when you were taking cyclobenzaprine and other drugs, do you think you were having trouble focusing your eyes?
Yes. Totally. Why do you think I didn't read? Oh, this is my new sleeping pill.
Oh, that's quetiapine. What's that supposed to do for you?
Help me sleep. It took a week to help me. It took a week to help me. Even with my glasses, I couldn't read properly.
But you never made the connection to the drugs?
No, I didn't. I didn't even think about that because my cognitive thinking was gone.
They were prescribed by a doctor. What more can I say?
You do what you think is best for you because a professional is telling you.
So just another thank you to Tom for taking the time to prepare those videos and share them with us. I think they're very educational. So a final reminder for you, our suggestion is to frequently monitor for anticholinergic harm and being careful to ask the questions to make sure you elicit the well-recognized toxicity of anticholinergics, but also the not so well-recognized or the subtle manifestations of toxicity. And every time a medication review for a patient is done, to make sure that you're alerted somehow to the drugs on the list that are anticholinergic, and you question the indication and you reassess the need to continue, keeping in mind that potential signal for the increased risk of dementia in, if the data is true, 1 in 12 people. And I'll end with this slide and say that, again, everything that we've talked about should be in this letter. The video recording of this webinar will be posted in the next several days, so please be patient. If you want education credits, keep an eye out on your email for the evaluation form. Please fill it out and then be patient. Within the several days after you submit your evaluation, you'll be sent a certificate with the education credit. And we also use the evaluation forms for a number of things, like what time of day do you prefer for webinars, what topics are you interested, what worked well, what didn't, and also things like, are you happy that they're free? Would you be willing to pay? So there's a lot of information that we pay attention to when you submit your evaluation forms. So once again, thank you. And hopefully there's some questions or comments in the chat. Alan, are you?
Sure. Can you hear me okay?
I can, thanks.
So there's lots of questions, but see, I've grouped a couple together. So let's start with which antidepressants do you think have the least anticholinergic effects? And then possibly the effects of duloxetine.
Oh boy, to be honest, I don't know off the top of my head in terms of anticholinergic burden, which would be the least to the most. I don't know if Tom is able to unmute. Tom may know off the top of his head. I'll certainly make a note of that question and try to find an answer. So if the person that's asking, you can email it to me and I'll make sure I'll get you an answer if there is one. Tom, are you around? Okay, well, I'll make a promise to try to get an answer to the person that wants to know.
Sure. Okay, what about second generation antihistamines for seasonal allergies? What can you say about their anticholinergic effects?
Again, I'm no expert. That one observational study where I flashed up the conclusion said that they found a stronger signal with the first generation antihistamines. I think if you were to look at the published information, they would suggest that maybe the second generation antihistamines have lower affinity for some of these receptor types that would produce toxicity. But that is not to say that some patients who are on second generation antihistamines might experience anticholinergic toxicity. So I don't think they're free of problems. They may happen less frequently, but I still think it's something that we should be watching for. Okay,
just briefly, what about toxicity in patients who have trouble communicating? You know, how would you tease that out? And another question, is there a patient kind of facing questionnaire that you would use?
Okay, so for patients that have difficulty communicating in terms of maybe they're, I guess, unable to speak for themselves, or if there's a language barrier, trying to get the family involved and maybe give those carefully worded questions to the family members if there's an issue of language. If it's in residential care where the patients have difficulty communicating or articulating their thoughts, maybe checking in with the nursing staff and giving the nursing staff the list of these more plain language questions so that they can look for those issues specifically, or checking the nursing notes for issues related to comments about bad breath or tooth decay or bleeding gums or issues such as those. We don't have a specific questionnaire that we've developed, but I think if you wanted to start tomorrow with your own questionnaire, just go back to the Homer Simpson slide, and that covers some questions that you could start using tomorrow. I will make a note to see if other groups, because there are many other groups around the world that are concerned about this drug class, if they have come up with a list of questions that can be shared. So if I find something, I'll make sure we find a way to post it on our website or alert people to it on Twitter.
Excellent. What about your old friends gabapentin or pregabalin and their anticholinergic effects?
I wasn't aware that they were potent anticholinergics. But again, I'd have to check with Tom, our resident pharmacologist, a clinical pharmacologist.
And do you know off the top of your head about opiates in which you think might be better or worse in terms of anticholinergic effects?
Not in terms of in terms of degree of causing problems, which are the best or the worst. No, I'd have to look and get a complete list. So given that there's questions about this, I think I'll have to work with Tom to put together some list that maybe we can post as a appendix to the letter on our website.
Okay, yeah, just Tom noted that he said that you can always take a look at the adverse effects and our clinical trial section of any Canadian product monograph for duloxetine or mirtazapine or quetiapine as examples. You can see that they cause dry mouth much more than the placebo comparator. So question on, is there a suggestion as to who out of the 1 in 12 are more susceptible to dementia?
Well, if you read the observational studies, several of them use some way to characterize patients as to their anticholinergic burden. So they have a way of saying how many dose equivalents, depending on the drugs patients are on. So it takes into account anticholinergic potency based on the product monographs and duration of exposure and how much daily exposure. So if you're on so many equivalents of a certain amount of dimenhydrinate or diphenhydramine. And the plain language short answer to the question is the longer the exposure to higher doses or higher potency drugs, there seemed to be a suggestion that the risk was higher. So given that information, long-term exposure, it would be, anything more than several months or more than just as needed use. The woman that was driving the Island Highway on the high doses of diphenhydramine, I mean, that's a very extreme example, but there are people that use anticholinergics for sleep every night and probably have been doing so for years. So it would be someone like that you'd be most concerned with.